Thank you so much, everyone, for joining us for this special webinar tonight in celebration of Balance Awareness Week. My name is Sheila Woodhouse, and I lead the Vestibular program, or sometimes known as the Dizziness and Balance program, a little simpler, at Lifemark, and I'll be your moderator for tonight's session. As is evidenced by the number of people who signed up for this event, boy, this topic is a hot one. The symptoms of dizziness, which it's kind of a general term, a catch-all term. It's a sensation of just general disorientation, or the sensation of vertigo, which is a little bit more defined. It's an actual sensation of motion taking place that isn't actually occurring. These are very common symptoms. And they're also very challenging symptoms for the medical community to get to the bottom of, because there's just so many things that can contribute to those types of feelings. Anything from medications to anxiety to cardiovascular problems and everything in between. And one of those things that's in between is if people have a problem with their vestibular system. That's a pretty common cause of these sensations. And if you haven't heard the word vestibular before, don't worry. We're going to find out all about it because I'm excited to have a couple of my highly knowledgeable vestibular therapists here joining us tonight to help enlighten us on what these common culprits are in the vestibular realm that sometimes give people problems. The first thing I want to do is start with a land acknowledgement. So Lifemark Health Group team acknowledges that our work spans many territories and treaty areas. We are grateful for the traditional knowledge keepers and elders who are with us today, those who have gone before us, and the youth that inspire us. We recognize that the land and the benefits it provides all of us, and we invite everyone to reflect on the past and present history in their particular geographic area, and for us each to think about what we can do to work toward reconciliation. Next, I have a few housekeeping items. As you will see, you're not able to unmute yourselves or turn your cameras on with this number of people. So if you do have questions, please use the Q&A function. If you're not seeing it, just hold your cursor over the screen and give it a little wiggle and you'll see a Q&A pod pop up at the bottom. Don't use the chat pod. We won't actually be monitoring the chat. So put your questions in the Q&A. And we've got two more of my vestibular therapists, Terry and Andre, busy in the background to answer those questions coming in as fast as their little fingers can type. But if we get to the end and your question wasn't answered, I'll tell you how to reach us to ask further questions or how to find someone near you if you decide you want to pursue this kind of care. So you don't need to ask that in the Q&A. If you are getting ready to type in your whole scenario and ask for advice, I'm afraid that we're unable to give individualized advice in this platform. These are medical conditions and our regulatory bodies don't allow for us to advise on treatment options without having done an assessment first. So I'm afraid that questions of that nature we won't be able to answer. Also, before you ask us in the Q&A whether it's going to be recorded, yes, this will be recorded and we will be posting it along with a summary in the blog section of our website, lifemark.ca. And also as a participant, you'll be sent a link and also a little summary at the end as well. So you don't need to worry about that. For those of you who are not familiar with Lifemark, we are the largest physiotherapy company in Canada. And as you can see from the slide there, we have hundreds of clinic locations across the country, coast to coast, and thousands of clinicians who work hard to help Canadians with their quality of life and their medical wellness. I am a little bit biased, of course, but my vestibular therapists in particular are very passionate about this work. They find the area fascinating and they love the detective work that's involved in helping people get to the bottom of what's making them dizzy and helping them with their journey towards wellness. I'm happy to introduce two of those therapists who will be our speakers tonight. we are going to hear from Taylor Jones, who is from our Vancouver Kiefer Place location. And I found all sorts of fascinating things out about our two speakers when I was reading their bios. I had no idea what some of these interesting tidbits. So Taylor actually graduated from Vancouver Island University with a Bachelor of Music in Jazz Studies. So that was fascinating. So then he obviously switched gears quite a bit and ended up doing a kinesiology degree at the University of Calgary, and then a master's degree in physical therapy at the University of Alberta. Taylor's worked with a large diversity of patients, ranging from people who are new to exercise all the way up to Olympic athletes. He's volunteered as a physio with Alberta Ballet, Theatre Calgary, and Skate Canada. He has extensive postgraduate education in pain science, concussion, vestibular management, manual therapy, functional dry needling, and acupuncture. We will also be hearing from Victoria Coe, and she works at our Olympic Oval location in Richmond, BC. Victoria graduated from UBC with a Bachelor in Human Kinetics, and then she traveled to Australia to complete her Doctor of Physiotherapy degree at Bond University. Victoria's completed additional training in vestibular, concussion, and pelvic health rehabilitation. And she also speaks fluent Fukien and conversational Cantonese, Mandarin, and American Sign Language. So wow, between these two, we've got a lot of skills represented. Thank you both for joining us tonight to share your expertise. Okay, so let's delve into it here. Vestibular. It's not a word that's familiar to a lot of people. It's not a household word. Taylor, can you maybe start us off by giving us all a bit of a high-level overview of what the vestibular system is and what role it plays for us?
Yeah, absolutely. I'm hoping you can hear me okay.
Yeah.
Perfect. So the vestibular system, you can see it in this picture here. It refers to part of the inner ear. And so in the picture highlighted in blue on the left side of the screen, there's an organ within the inner ear. There's a kind of swirly part and then another part that looks like three rings. And so the vestibular system refers to the part that's those three rings. There's a nerve that attaches to that organ that goes to our brain and other areas like our eyes. And that gives us very valuable information that we need to know where we are in space and helps us maintain our balance and things like that. So on this slide, it just gives a little bit more detail about the vestibular system and how it helps us live our lives. It's basically a diagram that is showing how the brain receives information from multiple body systems. So it receives information from the vestibular system, our muscular system, our visual system, our auditory system, and then the brain is going to integrate that information with information that we have from past experiences and send output signals to other body systems, like our eyes and our postural control muscles. Within the world of like vestibular therapy, we think a lot about how this affects the eyes, because the signals that are going to the eye muscles are very important to ensure that we can see clearly when our head and our body is in motion. Another term for that, it's kind of a technical term, it's gaze stabilization. So that will probably come up later on in the presentation.
Great. Yes, it's a very intricate system. And I think people have a bit of an idea that it relates to our ability to balance, but I think that people are often surprised to hear that it has anything to do with vision. So the fact that our inner ears actually are what are responsible for helping us see clearly when our head moves is quite fascinating, I think, for most people. Thank you for that overview. Now, people don't need a doctor's referral to see us, but a lot of our patients do come to us from their doctor, and often they come with a referral that says vertigo. Now, vertigo is really just a symptom. It's like pain. It's not a diagnosis. And so sometimes the doctors simply mean, yeah, this person has this symptom. Can you help us figure out if the vestibular problem responsible or not? But more often than not, when the doctors send a person with vertigo on the referral, they're actually referring to a specific type of vertigo that is actually a diagnosis, but it's a bit of a mouthful. So they just use the one word. So Taylor, can you just tell us what the doctors typically mean when they say vertigo?
Yeah, absolutely. And you're right. It's a symptom, can be related to many different diagnoses, just like the symptom of pain can be related to many different diagnoses. But in this regard, we're talking about the specific diagnosis of benign paroxysmal positional vertigo, which is a mouthful, but you can call it BPPV for short. And it's the most common cause of vertigo related to the inner ear in adult populations. And so what happens with this condition is that crystals that are within a chamber in the inner ear, they can become dislodged. And then those three rings on that picture on one of the previous slides, those crystals can enter the canals basically where they're not supposed to be. When they're in there, they'll probably disrupt the normal fluid of movement within those canals. And then that affects the nerve signals that are going to the brain, causing a mismatch of signals compared with the information your brain's getting from the other ear, resulting in vertigo or that sensation like something's moving, like maybe the room is spinning around you, or maybe you feel like you're moving when there's actually no movement happening. So that's a broader overview of BPPV. If we could
Got
move
a
to the
good video
next
of it on the next slide here.
slide. So what you're seeing in this video, it is a video, that inner ear organ, as the individual is, in this case, resting back, they're tilting their head backwards. Those crystals that are now free floating within the vestibular system are going to migrate to where they should not be, which is within those semicircular canals. Again, disrupting the movement of the normal movement of fluid within those canals and sending aberrant signals to the brain. And next slide, please. So with BPPV, there are certain signs and symptoms that we're going to be looking for. First of all, we're going to be talking to the patient, getting an idea of how this started in the first place. It's often going to be described as a kind of sudden, random onset. Maybe that person just got out of bed one day, or they were in bed and rolled over onto a specific side, and they got this sudden severe spell of vertigo that probably just lasted for a few seconds. We try to categorize it as like lasting for less than a minute or so, but it is usually just a few seconds. In the clinic, in an assessment, we're also going to be assessing for something called nystagmus. And nystagmus is rapid, repetitive, uncontrolled movements of the eye. And so those are some of the big things that we're going to be looking for to diagnose BPPV. And also important to note, as it says on this slide, that if symptoms occur when you haven't moved your head, maybe that individual is just sitting still, they've been sitting still for a while, they get this sudden wave of vertigo or dizziness, then that's not characteristic of BPPV. It is probably something else.
Right. Yeah, so I noticed that when I ask people which movements in particular tend to bring on their spinning sensation when they end up having this condition, there's usually some pretty common themes. What do your patients tend to say to you about when you say, okay, what makes the room spin? What positions do they say? Because I think it might resonate with some of the people from the audience, and they'll say, oh, I feel that too. What do they experience typically?
So typically what I hear is like laying down is very common, especially on one side versus the other. So they might say, every time I lay on my right side, I get this sudden severe episode of vertigo, just lasts for a couple seconds, but it's very scary and very sudden. So typically they will just avoid sleeping on or laying on that side. In an assessment, we want to test with actually provocative tests. So we're going to get those people into those provocative positions. With a couple tests, very commonly used are the Dix-Hallpike test and the supine roll test. And in those positions, we're going to be looking for that subjective report of vertigo because they're in that provocative position. But we're also going to be looking for that nystagmus or eye movement that should correlate with the onset of vertigo.
Great. I think we've got a cool video of it next here.
Yeah, so this is a video of someone performing the Dix-Hallpike test. And this video also illustrates that nystagmus. It only lasted for a couple seconds there, so we'll play it a couple times. The therapist is bringing the patient down quite quickly into that provocative position, head tilted to the right. So they're testing for the right ear in this case. And there's more variables than just which ear it is. We also want to know which canal it is. We're assessing the quality of the nystagmus when it's occurring, the duration of the reported vertigo, severity of the vertigo, all those sorts of things. So for a lot of people, when this happens, it is quite scary because it can be very intense and unexpected. But the good news is that in 90% of people with BPPV, it will resolve within 1 to 3 treatments. And so what treatment looks like is called canalith repositioning maneuvers. One example of which is the Epley maneuver, but there are many different maneuvers. And with these maneuvers, we're moving the head and the inner ear through a series of positions that are going to utilize gravity to drag those crystals through the semicircular canal, ending in a position that puts those crystals back into the chamber where they are supposed to be. And then hopefully they stay there or just get reabsorbed by the body. But we do want to test to make sure that we got all the crystals, and also to confirm that we were treating the right canal in the right spot. What treatment can also involve is more vestibular therapy, because with this condition, maybe someone's been dealing with it for a long time. Maybe they have been avoiding some positions or some activities. And so that can lead to some deconditioning or some ongoing balance deficits or motion sensitivity. So vestibular rehabilitation will often try to address any deficits that might be happening as well.
Great. Yeah, so you talk about it resolving in 1 to 3 visits, plus maybe another few sessions if there is that residual motion sensitivity or imbalance, which is pretty common afterwards. But I think as therapists, we've all seen patients who've come to us saying, you know, I've been getting these maneuvers twice a week for the last 6 weeks and it's not changing. So yeah, getting these maneuvers over and over again and not getting these types of 1 to 3 treatment outcomes that we would hope for here. What's your take, Taylor, on what might be going on in those sorts of situations?
Yeah, so we want to make sure that we're applying the correct treatment. Like I mentioned, there are many variables to identify with BPPV. We want to know the correct ear, the correct canal, and also the correct variant of BPPV. It's kind of too in-depth for this discussion, but there are subtypes of BPPV as well. So we want to make sure that we're giving an accurate diagnosis to provide correct treatment. Sometimes BPPV is not the correct diagnosis, however. There are other conditions that can mimic BPPV. So someone might have been receiving treatment for BPPV when it's actually something else.
Mm-hmm. Yeah, and this next slide that you're seeing here is a good segue, because vestibular migraine actually is one of those things that it can mimic BPPV on a certain level. It's got a few similar characteristics, but obviously it's not going to respond to repositioning maneuvers. So maybe at this point, Victoria, can you jump in and tell us a little bit more about vestibular migraine? It's quite an interesting condition.
Sure, of course. Let's start with what exactly is a vestibular migraine. It is the most common neurological cause of vertigo amongst adults, and it's typically referred to as dizzy migraines because it's like a typical migraine, but with vestibular symptoms added on. But what can be confusing is that when you think of migraines, we usually think about a pounding headache. But with a vestibular migraine, a headache isn't always there. So about 30% of people who experience typical migraines also experience vestibular migraine. So they may be experiencing some dizziness, vertigo, or they feel like they're off balance a little bit during their migraine attacks. But even between attacks, those with vestibular migraines can have some balance issues and motion and visual sensitivity. So because they are similar, triggers for a typical migraine can also trigger a vestibular migraine. Some common triggers can be dehydration, stress, irregular sleep, changes in hormones. So for people who menstruate, they can experience vestibular migraines during certain phases of their menstrual cycle. Certain foods can also be triggers, such as chocolate, caffeine, or alcohol. We still don't really understand what causes vestibular migraines though, but when I see patients who have this condition, they're often typically middle-aged women who have had migraines in the past or have family members with migraines. They also often report having motion sickness. So usually they report and they say, oh, I avoid sitting in the backseat of a car, or they avoid going on rides when they're at the fair or at the carnival. Okay. So now let's talk about what symptoms to look for a vestibular migraine. As you can see from the table on the screen, the symptoms are quite similar, except for a few points. Both types of migraines can have sensitivity to light and sound, feelings of nausea and or vomiting, and an aura. So an aura is something that is experienced before a migraine hits. Typically, it's some sort of visual disturbance, like seeing bright flashing lights. Now, what makes vestibular migraines different than typical migraines is that, number one, there isn't necessarily a headache associated with it. And number two, they will be experiencing vestibular symptoms like vertigo and dizziness. The vertigo that they may be experiencing can be a feeling of their own body spinning, or it can be an external vertigo where they feel like their surrounding is spinning. Or a third type is that the vertigo can be triggered by head position and movements. And these symptoms usually last between 5 minutes and up to 72 hours.
Okay. Yeah, I personally get traditional migraine, and all those things in the blue column look pretty familiar. But I also do sometimes get a bit of dizziness or some unsteadiness with my symptoms, but I wouldn't necessarily say that I have vestibular migraine. How do you make the distinction between those two diagnoses? Where does it sort of cross over?
Yeah, diagnosing someone with vestibular migraines can get a little tricky because both types of migraines share many of the same symptoms as we saw. And what makes it more difficult to diagnose is that vestibular symptoms with a migraine does not equal a vestibular migraine. So in your example, Sheila, if you suffer from typical migraines, like the traditional kind, but once in a while you experience some dizziness, vertigo, or some unsteadiness during your migraine attacks, that doesn't necessarily mean that they are vestibular migraines, because medical testing and matching the symptoms with a criteria needs to be done in order to accurately diagnose someone with a vestibular migraine. So medical testing needs to be done to rule out the possibility that there could be other causes for symptoms. So the patient may be referred to specialists such as neurologists for brain imaging by CT scan or MRI to rule out any neurological causes such as a stroke. Referrals to other healthcare practitioners is also important, such as referral to an inner ear doctor or a vestibular therapist. We can evaluate the function and health of the vestibular system. When someone goes to their appointment with a vestibular therapist for an assessment, their whole vestibular system is assessed. We will test for things like things that concern the brain or their nervous system, their balance, eye movements. We also test for BPPV, which we just learned about, motion sensitivity or gaze stabilization issues. And these are important to address because these issues can, if we manage these issues, it can really help manage their vestibular migraines. Now, when someone comes into the clinic and they're wondering why they're dizzy, and we're trying to figure out if they possibly have vestibular migraines, we would ask them a few questions to see if they fit the diagnosing criteria. So on the slide here, it's the first criterion. The first question we would ask them is if they've had vestibular symptoms on at least 5 of their migraines. So the person should have had at least 5 episodes of vestibular symptoms of moderate to severe intensity that last between 5 minutes to 72 hours. So these vestibular symptoms can be vertigo, dizziness, or unsteadiness. Another question we would ask that builds off that first criterion is if half of those episodes from criterion number 1 was accompanied by at least one of these symptoms. So either a headache, sensitivity to light or sound, or they need to be experiencing visual auras along with the migraine. Now, I mentioned in a previous slide that a headache does not necessarily have to be present in a vestibular migraine. But if the person does experience headaches, then the criterion is that the headaches need to include at least 2 of the following features. It needs to be one-sided, throbbing of moderate to severe intensity, or aggravated by physical activity, so worsened with body movements or exercise. The third question we would ask is if they currently experience migraines or if they have a history of migraines. So that's pretty simple. And then the fourth and final criterion would be if they have been tested and assessed for everything else, and the only thing that makes sense is a vestibular migraine diagnosis. All right. So treatment for vestibular migraines is similar to a typical migraine in that a combination of lifestyle changes, medical intervention, and vestibular therapy can help manage their symptoms and help reduce the intensity and frequency of their vestibular migraines. Certain medications and supplements can be helpful, so a doctor can help prescribe the right ones for them. Potentially beneficial supplements include riboflavin, magnesium, vitamin D3, melatonin, and coenzyme Q10, but the evidence regarding how effective these are is still being studied. A vestibular therapist can provide them with information to help manage their symptoms and to help with some of the vestibular disturbances they may have. Now, what people can do for themselves is to work on lifestyle changes, such as regular exercise, especially aerobic exercise. It's been shown to really help. So activities that increase your heart rate and make you breathe a little harder is considered aerobic. Proper sleep hygiene is also important. So for example, setting up a schedule where they wake up and go to sleep at the same time to build a routine is also very helpful. And lastly, dietary changes, stress management, and avoiding foods that are known triggers to them. So to summarize what we just went over, vestibular migraines is the most common neurological cause of vertigo in adults. It affects women in their 40s with a history of migraines, history of motion sickness, and a family history of migraines. Vestibular migraines and typical migraines are very similar, so they share many of the same symptoms and triggers. And to accurately diagnose this condition, medical testing and matching their symptoms to the 4 criterion is needed. And the most important thing is treatment that includes medical management, lifestyle changes, and vestibular therapy results in really good outcomes for them.
Terrific. Thank you. So now we've heard about a couple of conditions that can give you episodes of dizziness or vertigo lasting anywhere from a few seconds if it's BPPV up to 72 hours if it's a vestibular migraine. But what about people who have long-term daily symptoms been going on for weeks or months? Taylor, what can you tell us about another common culprit that might explain that scenario?
Yeah, so next we'll talk about vestibular neuritis and labyrinthitis. So 2 very similar but sort of distinct conditions. And unlike BPPV, which is episodic, these conditions are actually pretty much constant. They are the second most common cause of dizziness and vertigo related to the inner ear. And it has to do with inflammation of either the vestibular nerve or the vestibular labyrinth complex, which are pictured on this slide. Something they have in common with BPPV is they're both a mouthful to say. So a simple name for this is an inner ear infection. Anytime in medical terminology, when there's itis at the end of a word, it means that there's inflammation. And so with these conditions, vestibular neuritis means inflammation of the vestibular nerve, and labyrinthitis is inflammation of the vestibular labyrinth that the nerve attaches to. So symptoms with vestibular neuritis and labyrinthitis, it's likely also going to be a sudden severe vertigo, but it's going to last for at least 24 hours. It's continuous, as I mentioned, different from BPPV because BPPV is episodic. So with these inner ear infections, it's going to be causing vertigo even at rest. It does tend to be worse with head or body movement, but even at rest, there's going to be some degree of symptoms. And those symptoms last they can last for the duration of the infection, but they're typically the worst within the first couple days. And that's when the vertigo is the most intense. Other symptoms can include nausea and vomiting, a sense of unsteadiness, and often there's something called oscillopsia. And so oscillopsia is an issue with vision, where objects that someone is focusing on appear to be vibrating or jiggling. So we would hope that once the infection runs its course, these symptoms would go away and resolve. But it is possible that the infection can cause some lasting damage to some of the structures in the inner ear. So if that does happen, then symptoms may linger for months or even years beyond the infection until the brain figures out how to compensate for that damage. So just like these other conditions that we're talking about today, there's specific testing that we would do with a patient coming into the clinic for an assessment who's been dealing with dizziness or vertigo. And so with inner ear infections, we're going to be looking for nystagmus, or those irregular eye movements, similar to BPPV. But the quality of that nystagmus is going to look a little bit different. With both conditions, we actually will probably use these blackout goggles. They're sometimes called Frenzel goggles, but they will put the patient in the dark, so they won't be able to see anything, but the therapist will be able to see how the patient's eyes are behaving because there's an infrared camera attached to the goggles. And then with those goggles on, we get them to do eye movements and other tests that may provoke some dizziness or some increase in symptoms and nystagmus. So that's a big part of the assessment process. Other tests that we want to use in an assessment will assess motion sensitivity, balance, general vestibular function, and vision during head movement, otherwise known as gaze stability. So these tests will help determine if there's a persisting loss of function after the infection, or if the infection has run its course and not left any deficits to any of those symptoms. If there is some damage and things aren't working quite as well as pre-infection, then that can result in what's called a unilateral vestibular hypofunction, or UVH. And so a hypofunction is when it's functioning less than it was previously. Just like all these other conditions, also just the subjective history, what the patient is reporting, is a vital part of the assessment process as well. And so treatment for this condition, it also looks very different from the other pathologies that we've talked about so far. So because it's an infection, good idea to have the doctor on board. They may want to prescribe some medication. That might be to deal with nausea, the infection itself, and inflammation to help manage the symptoms acutely. It's not recommended beyond the acute phase to have ongoing medication for this. So that is generally something you just want to have in the acute phase. And then vestibular rehabilitation is going to be a big part of this treatment as well, especially if there are some persisting deficits or limitations after the infection. And so this will help things like restoring clear vision during head movement or gaze stability, help improving balance. And that might look a lot different. It might be just standing still, maybe standing on one leg, maybe playing sports. So like static or dynamic balance. Vestibular therapy will also help to provide desensitization to any triggering visual or motion stimulation.
Great, yes, vestibular rehabilitation. It's a pretty powerful tool. It's lots of research backing it up, and this stuff really works if people stick with it. When I am dealing with clients who have this condition, one of the common questions that I get, and Taylor, you can let us know if you hear the same, we talk about BPPV, where we can actually mechanically fix what's going on here. When you've got one of these hypofunctions, does the vestibular rehab actually fix the damaged ear, or what's the prognosis there?
Yeah, great question. And I do receive that question a lot. And so vestibular rehabilitation actually does not fix any damage to the inner ear structures. How it works is it actually trains the brain to compensate so that you don't feel the symptoms anymore, and it feels like things have returned to normal. But that's just the power of the brain and how adaptable it is. So yeah, it doesn't actually fix the damage if there is any damage. It just compensates.
Great, yeah, that's a great way of explaining it. Nice. The other question I get all the time is, okay, I'm going to commit to this training, but how long is it going to take? What do you usually tell patients when they ask you that? I get that all the time.
Yeah, so for a condition like this, with persisting symptoms, in the absence of complicating factors, usually about 6 to 8 weeks. We will typically see people weekly for the first several weeks to make sure that we have the right diagnosis. We're addressing all the variables and all the limitations, that everything's going well, and to provide appropriate progressions. And then later on, we want to taper off a little bit, more for fine tuning and really just getting things feeling back to normal and, being more functional, participating in more of the activities that they may have done prior to the infection.
So 6 to 8 weeks, that's great. As you did bring up the comment about if there aren't other complicating factors. And yes, sometimes things just don't go on schedule. Maybe people aren't sent for rehab until they've had problems for a long time. Maybe they have other illnesses, or they're on a lot of medications, or they're not moving around. Sometimes there's just these other factors that stall people's recovery. Victoria, can you talk to our audience about the people that we sometimes see who have really long-standing vestibular issues that just aren't coming along? That's also quite common.
Yeah. One of the possibilities of an ongoing cause of dizziness is a condition called triple PD, which is short for persistent postural perceptual dizziness. It's
Why
a
does vestibular
long,
always have so many long mouthful terms? They really need to shorten all these things.
that's right. So we're just gonna call it triple PD. It's a long-lasting sensation of dizziness and unsteadiness and a non-spinning type of vertigo that may last for months and sometimes years, which is why it's considered a chronic disorder. So with triple PD, it affects females more than males with a ratio of 4:1. And it typically occurs after a vestibular insult, like an ear infection or BPPV, or a medical issue that caused dizziness, such as an episode of psychological distress, like a panic attack, or a cardiovascular event, like a stroke. All right, yeah, next slides, good. So because of the sudden vestibular insult, there is a sudden change in the brain's ability to interpret space and motion. So following the alarming event, the fight or flight aspect of a person's nervous system is activated, which changes how space and motion is perceived for them. And once the alarming event stops, instead of the brain resetting, the brain maintains that abnormal perception, which causes the sensation of dizziness and unsteadiness. And these sensations can last for 3 months or longer, like I mentioned. So basically with triple PD, the body holds on to that feeling of being off balance. And even after the initial event passes, someone with triple PD remains hyper aware of things that affect their balance, like their posture and their surroundings. And this heightened awareness often leads to anxiety and affects their mental well-being quite a bit. So what perpetuates the symptoms is instead of the brain helping, the brain is now hyper aware. And this prevents their brain from processing sensory information from their eyes and their muscles and their inner ear, which is the best way to help us stay steady on our feet. But instead, their brain relies too much on sensory input from what they see in their surroundings and how they're positioning their bodies, which causes them to rely less on their vestibular system.
I'm seeing that you're also noting some psychological factors there that can contribute. Yes. And when it comes to the psychological piece of things, I will just say that for people who have dizziness or vertigo issues from any cause, it would be really quite unusual for it to not have a psychological impact. Suddenly you have these symptoms in your life that are affecting your quality of life. So the psychological piece to all of this is very common. But what's the scenario where things kind of cross over from the normal psychological impact that we get if we have these symptoms into what would actually get into this triple PD or 3PD territory?
Mm-hmm. Yeah, so we typically look at their symptoms to help us differentiate triple PD with other disorders. The primary symptoms are dizziness, unsteadiness, and non-spinning type of vertigo. And so sometimes people describe the dizziness in different ways. So for example, They can say that it feels cloudy or heavy in their head. And the unsteadiness, they can sometimes describe it as feelings of being unstable when they're especially in an upright position, or when they're walking, they find that they veer more to one side. The non-spinning vertigo can also sometimes be described as swaying, rocking, and bouncing. So we kind of listen to how they're describing their symptoms, and that helps us kind of go down the path of triple PD. People do report that they experience symptoms in the background throughout the day and feeling it pretty much every day. They might have symptom-free periods, but they don't usually last long. Also, throughout the day, the symptoms may fluctuate and get exacerbated by upright postures, motions of their own body, or motions outside their body, like when they're sitting in a moving car, or if they're looking at a complex visual stimuli, like a crowded grocery store. So this condition, triple PD, is a bit challenging to diagnose because there are no physical signs of the disorder. Tests such as blood analysis or brain imaging can all come back normal, and healthcare providers will typically run a lot of different tests to determine if what the patient is feeling can be something of another disorder or disease before diagnosing them with this condition. So a big part of how this condition is diagnosed is based on the person's symptoms and their medical history, and if the symptoms are causing significant distress to their life for at least 3 months. So I think we can move on to the next slide. Yes.
Yeah.
So a big part of diagnosing them is really thinking about and listening to their symptoms. Other important parts of the diagnosing criteria is that their symptoms are exacerbated by, number 1, upright postures. Number 2, active or passive motion without regard to direction or position, and exposure to moving visual stimuli or complex visual patterns like a checkerboard, and also that their symptoms were preceded by a condition that did cause vertigo before they started to feel the symptoms of triple PD.
Yeah, this condition could be really quite distressing for patients because, like you said here, a lot of the testing normally is just coming back totally normal, and patients say, I've had all this testing, everyone's saying everything's normal, but I know something's wrong, and now people are starting to hint that maybe it's all in my imagination. What do you say to reassure those folks?
Yeah, we really do hear that a lot, unfortunately, and these patients may start to think that they might actually have a psychological disorder instead. But I always make sure that they understand that this condition is a complication of healing with real changes that happen in their brain and the pathways in the brain. So researchers have actually seen these changes with special MRI machines that scan their brain. So it is definitely a physiologic disorder with psychological consequences. And sometimes it's the psychological consequences that become the biggest part of their challenge dealing with this condition.
Yeah, that's a great way of explaining it. Nice.
Okay, now
Let's talk slides here. Great.
Let's go back to the previous
yeah.
slide. Yeah. So we'll just talk a little bit about the treatment options. Patients typically respond well to a combination of the 3 treatments that you see on the screen: medication, vestibular therapy, and counseling. The majority of people with triple PD respond to antidepressant medications, so they may have to work with their doctors to figure out which type of antidepressant medication is the best fit for them, because there are a few different ones. Vestibular therapy is also a treatment that can help with this condition. The goal of vestibular therapy is to help them, help their brain relearn how to balance and become desensitized to certain triggering movements like head turns. And lastly, many people do find that talking to a counselor can help support them and provide them with coping mechanisms for this condition, especially if they're finding it difficult to manage the psychological aspect of the condition. All right, so to summarize triple PD, is a long-lasting cause of dizziness, unsteadiness, and non-spinning vertigo. It affects mostly women with a ratio of 4:1. It typically occurs after a vestibular insult, like an inner ear infection or BPPV, or a medical episode that caused dizziness, like a cardiovascular event or an episode of psychological distress. Diagnosing this condition is challenging because medical testing will usually come out normal. So diagnosing this condition relies a lot on matching an individual's reported symptoms to the criteria. And finally, the treatments for this condition do help patients get back to some sort of normality.
Terrific. Well, thank you so much, Taylor and Victoria. Don't go away because we might have, I know we're running a little tight on time, but we might have a chance for a question or two at the end. What I'd like to do next is introduce a special guest, Alessandra Gabriel, and she's with our partners at PC Health, and she's going to just talk for a moment or two on the cool PC Health app and also a vestibular health journey that we've recently put on the app to help people further explore whether a vestibular issue might be what's responsible for their symptoms. So Alessandra, can you tell us a little bit about this?
Hi, yes.
Sure.
Hello, everyone. Such a pleasure to be here today. Big thanks to the Lifemark team for all of the education and expertise that they provided today. I learned a lot, and I hope you did too. I'm a manager over on the PC Health team, and a little bit about PC Health in case you aren't familiar. PC Health is a service that helps and allows Canadians to have better access to care through a variety of features. One of them being in-person or virtual care options, as well as free chats with nurses on the app. It can also allow you to manage your prescriptions, whether that's refilling them, receiving pickup notifications, and seeing all of your medical history. You can also achieve your health and wellness goals through a variety of different health programs, and you can also get the opportunity to earn some PC Optimum points while you're at it. And so just to be a bit more relevant to the topic today, we did partner with Lifemark to create a new program called Explore the Culprits of Vertigo and Dizziness, which will explore some of the topics discussed today. So if you're interested, feel free to scan the QR code, and that will allow you to download the app and learn more about it. Big thanks again for the Lifemark team.
Great. Thank you for sharing that with our viewers. Great resources. Okay, we may not be able to take more than a question or two at the end here because we're down to the wire, but hopefully you got your question answered in the Q&A by Terry or Andre. But if we didn't get to yours, please just feel free to email us. We'd be happy to answer your questions in that manner. If you're interested in a little bit more information about our dizziness and balance service in general, there you can see the website address on the bottom there. Just go to our website, lifemark.ca, and you'll be able to find the vestibular service on there to learn more. If you are inspired by what you've heard tonight and you want to see us for an assessment or recommend this for a loved one, there is a QR code that you'll see there that will take you to a page where you can find a location close to you that has a vestibular therapist to help you. Or again, just if QR codes aren't your thing, just go to the website or shoot us an email or give us a call. Our call center would be more than happy to point you in the right direction. Also, if we don't have a location near you, if you live out in the boonies somewhere, actually vestibular rehab lends itself quite well to virtual care. So if we need to do that, that's an option as well. If you're listening tonight and you're going like, those conditions that they described, it doesn't quite sound like what I'm experiencing, don't despair. That we only talked about 4 of the most common things that we see, but we see so many other conditions that can give these types of symptoms, and we can identify lots of other things and help you with treatment as well. Also, you'll see on that slide our social media platforms. And so if social media is your thing, I encourage you to follow us on one of those platforms, because we regularly share lots of information on different topics that might be helpful to you or a friend of yours or a family member. So please follow us. We will just take a question or two here at the end. One question that did come up a few times I saw is, and I hear this all the time too, people wonder, how long do I put up with these symptoms before I seek treatment? Might it just, it's feeling a little better, but will it just go away if I wait? What might people consider in the decision making on that? Taylor,
Yeah.
do you have a comment
Yeah.
you could make to that?
I can speak to that. So generally earlier is better. I would encourage people to seek treatment right away. Yeah, research does support that early intervention does lead to better outcomes. That's because these conditions can affect quality of life, so you want to get them dealt with quickly. Some of them can increase fall risk, so you definitely don't want it to get to that point and have it lead to another injury or other complications. And yeah, these conditions can be quite scary. Some of them, like the first one we talked about, BPPV, the B stands for benign, so it's not as serious of a health condition as some other conditions, but you probably want to get it checked out, just to make sure that yeah, you're not waiting too long for something. So generally earlier is better. Yeah, what do you think, Victoria? Would you agree, or any other comments?
Yeah, I agree. If someone is able to seek treatment right away, it might reduce the likelihood of developing something else like triple PD if their initial condition is treated correctly in the first place. Because in the early stages of a person's condition, it can be helpful for us to be able to tell their doctors if we found anything that was not consistent with vestibular involvement. So hopefully that can help direct them to investigate and get to the bottom of why they're feeling their symptoms.
Great. Do we have time for another question before we wrap up? Well, maybe you take one here. Andre or Terry, did you have a burning question that lots of people asked in the Q&A, or a particularly interesting question? Anyone want to unmute there and
Yeah,
shoot
there's
one
one
last question?
question that came up quite frequently is, does home apply maneuver help with BPPV?
Yeah, the home Epley maneuver can definitely help with BPPV. As I mentioned in the BPPV content, there are lots of variables that we want to assess for. So it's still recommended to seek treatment with a vestibular therapist if this is something new. It can recur for some people, and if an individual has been taught how to do the home Epley maneuver safely and correctly for something that is recurring, then it can definitely be a good option. Yeah, it shouldn't be the first thought, I don't think, to just try it yourself for something that isn't diagnosed. But for something that is diagnosed and it has a high likelihood of success, then it can be a good option.
Yeah, good comment. Like Taylor said, there's lots of things that can mimic BPPV. The Epley maneuver only works for a certain canal and a certain variant. You've got to get a lot of things right for that to work at home. We are at the top of the hour. Gosh, thought we might get one more question. Andre, can we shoot in one last question that you saw that was pretty common, or do you agree with Terry that was the most common one? Okay, well, like I said, if we didn't get to your questions, you can certainly email us at info@lifemark.ca. I think in respect for everyone's time, we ought to wrap up here because we are at the top of the hour. So thank you to Victoria and Taylor for sharing your time and your expertise. Andre and Terry in the background answering all those great questions that I'm sure came in. Thank you for doing that. And also to everyone else in the background who makes these sorts of webinars come together. It's quite the process, actually. Kind of an eye-opener. And especially I want to thank everyone who attended tonight. We really appreciate your time and your interest in this topic. Watch your email. You'll get the link to the recording, and you'll also get a summary and a survey that's where you can share some feedback about tonight's session. And also provide, if you have some ideas on future topics you'd like to hear about, that will give you the opportunity to share that as well. So have a lovely rest of your evening, everyone, and the rest of Balance Awareness Week. And good night, all. Thanks kindly.